updates from our partners. We're now recording. So if you're in the WITSEC program, scoot out now, or at least turn off your camera. As I said, we've got a great presentation once we hear from our partners, and then we'll get you out of here as close to noon as possible. So without further ado, Steve DeLella, Department of Housing, updates.
Thanks, John. So I know I had Unite CT up there. As many of you know, I do not manage the Unite CT program. That is Don Parker of DOH. From what I understand, this program is actually picking up speed. May have had a little slow start, but now we're putting out over $1 million a day for rent relief for those who are struggling to pay their rent due to COVID. So I think we are probably approaching the $50 million of spent. So clearly, many of our programs here know about Unite CT. If you have anybody facing any problems, especially eviction, please send it along to Unite CT. They've done some major changes to the program to try to make it as user-friendly as possible, easy to access. So we still have a lot of money to go through. So please, if anybody has any questions or concerns directed to me, and I can get in touch with Dawn. But yeah, please look at this program. There is a lot of funding available. Now, in terms of the homeless services side, the emergency housing vouchers, we did receive our 380 here at DOH. We've already processed or allocated 200 of them to the cans. There are also additional almost 175 or so that have gone directly to the municipalities, specifically Stamford, Bridgeport, New Haven, and Hartford. And I know everybody on the cans are working with them as well to get access to some of those vouchers. There are a bunch of subpopulations that we're still trying to work with and figure out how best to connect with. So that will be coming for our second round of vouchers. So stay tuned to that. Another big issue that has been going on over the last few weeks and months after the budget passed is DOH did receive $5 million in each of the next 2 years into our general fund to be able to assist homeless shelters and homeless service providers. So we've been meeting, trying to figure out what the best uses is. And after our conversations, clearly cold weather funding is of dire concern for this upcoming winter, as is increasing wages across the board for shelter staff, because we know that many of those frontline workers do not get paid what they should. So we are still in conversations with that, but hopefully we're moving toward a resolution relatively soon, so we can start planning for a cold weather season. One additional update, looking for further guidance on extending the FEMA funding. My understanding is FEMA will extend non-congregate sheltering to the end of the calendar year. So that does give us a little extra time, as long as the state continues its public health emergency. So we're working on the internal mechanisms to be able to do that, so that we'll be able to continue hoteling through December 31st. If that does not happen, it will end at the end of the month. So we will certainly keep everybody posted as we move forward with that. So I will now pass it along.
Great, thanks, Steve. Joining us this morning from DSS is Sarah. She's got 347 slides, but she promises to go through them in as fast as possible. Just a reminder, you get the slide deck before the meeting. It just got dropped into the chat from Liz. If there are any questions, feel free to drop them in the chat. Those will be monitored, and we'll allow for time after Sarah's presentation to address those questions. So without further ado, Sarah, go.
Yes, good morning, everyone. I do have quite a lot of information, but we're going to breeze right through because a lot of it is repeat. So I'm going to start with some medical updates. So due to the public health emergency, Health and Human Services has allowed DSS to do whatever they can possible to maintain enrollment for most individuals who were enrolled as of March 18th, 2020 or after. Just keep clicking through the slides here. So this is some new information. Just on July 19th, the public health emergency was extended through October 20th. They do this in 90-day increments. And earlier this year, Health and Human Services did say that the health emergency will likely remain in place for the remainder of the year. We will be given 60 days notice prior to it ending. So we've already are more than 60 days. So chances are we will be in this emergency throughout 2021. There are some exceptions for the department having to maintain enrollment. Those are if somebody requests that their case be closed, if they move out of state, if they do not have an eligible immigration status, they age out a Husky B, they pass away, or if they were not validly enrolled. Some new information here is if individuals are found ineligible for any other reason than the above listed, we do not have to maintain enrollment if they do have a minimum essential coverage, also known as MEC. And an example of that coverage would be if somebody is on a Medicare savings program, we do not need to maintain enrollment on their other Medicaid. This is repeat information. Again, I added in here that unless somebody is enrolled in MEC, we no longer have to maintain enrollment. And we are still allowing for flexibilities, such as providing more information to get information to us, and the extension on the 90-day reasonable opportunity period for our MAGI medical programs is still in place. The income threshold that increased from 10 to 20% is still going to be maintained throughout the remainder of the PHE. And even though the reasonable opportunity period was extended, we are still asking that if somebody is information is requested of somebody, that they provide it as soon as possible. We'd much rather grant somebody an entire 12-month renewal period rather than these small extensions. And COVID testing and treatment continues to be covered under these groups. This is repeat information as well. We are still increasing access to care and are maintaining the flexibilities that were given to us under our 1135 waiver. And we're still streamlining our processes. The COVID-19 testing coverage group remains the same, except for effective March 11th. The vaccine is also now covered under this limited benefit group for the uninsured individuals. We are not covering the vaccine for non-citizens without a qualifying immigration status. Resources here. I think the next couple slides are some resources for you guys of how to apply. This is for the COVID-19 testing coverage. And the following slide is what the card will look like if somebody is granted the limited benefit. More resources for how to apply, MAGI coverage groups up top, and then our non-MAGI Husky C and other DS programs. Same, more resources for you guys to reference. And the governor's press releases related to COVID. I think we might have missed a slide before this one, but oh, here we go. Updates about the SNAP program. We have multiple retailers that are participating in online shopping now. They are listed here. And since March 2020, the department has been providing additional SNAP benefits to households. To date, over 400 million benefits have been supplied in addition to normal benefits. And this is new information. The USDA has reevaluated their thrifty food plan, and the SNAP benefit amounts are going to be increasing based on that plan for the first time since 1975. The next slide does have an example of the thrifty food plan to show you that since pre-pandemic, the amounts have increased significantly. And quickly, some updates from the Office of Community Services. The Connecticut Energy Assistance Program applications started August 1st, and they will begin fuel deliveries on November 1st. In order to be eligible for this program, households must have a member that receives DSS cash assistance. They are automatically categorically eligible if they do. And households with a member that receives SNAP benefits will be categorically eligible for level 2 benefit. There's no asset tested this year for this program. There were some additional flexibilities, and we aren't requiring risk assessments. Cooling assistance will be provided next spring and summer, as well as air conditioners for those with a documented medical need. The other program, the Low Income Household Water Assistance Program, is for eligible consumers, is for assistance with drinking and wastewater bills, and applications are based on priority, starting with those who have had services disconnected. The benefits for those who have had services disconnected could be up to $1,000, and those who don't can have $50 to $300 depending. These eligible households could also qualify for winter protection for their heating costs, gas and electricity, and any additional information can be found at the local community action agency or their utility company. Lastly, this is the information about the DSS office hours. They're open 8 to 4, Monday, Tuesday, Thursday, Friday. Wednesdays still remain as processing time for staff. So the offices and benefit center line are not open, but 24/7 access is available at connect.ct.gov or via the IVR system at 1-855-6-CONNECT. That is all I have.
You did a great job, Sarah.
Nice and fast.
Nice and fast. Any questions? Pop it in the chat or unmute yourself at this time. Going once, going twice. Sarah, did you give us your contact information on one of the slides?
I did not. I can enter it in the chat for you.
That'd be great. Thanks, Sarah.
Thank you.
Okay, moving on. Connecticut Coalition to End Homelessness. I see Linda Casey. You're up.
All right. Good morning, John. Good morning, everyone, and happy Labor Day Friday. Just a few updates. Last night, we put into HMIS a new update for almost every new client intake to have the vaccination questions included. So that's really going to increase our ability to track vaccinations. And just a best practice reminder, as you ask the person who is coming into your system or updating information, it's a really good idea to get proof that they have that and not just take someone's word. There's 3 ways you can do that. You can actually have them go to the provider, whether that's a pharmacy or a provider doctor that they went to get that. You can have them actually go to VAMS. If they have a VAMS account, they'll log in. And you can also have them go to CTWiz. All this information we'll send out in an email. But the point there is it's really important to get that vaccination confirmation and to store it if you can, if you get a copy of the card, to store it into HMIS. And if you can't get that, we really recommend that you put in a no vaccination status. It's really for the safety of everybody who is encountering that person until you can get confirmation. So that's really the update. We've got more projects that have the intake questions for vaccines and ability to just kind of understand what the best practices are. So any questions?
Going once, going twice. We know where Linda at least resides via email, so feel free to reach out to her. So just a couple slides from the balance of state. There is a COVID data tracker. Just a reminder that anything that's underlined is a live link. You can click on that and it gives us data at the county level. So just in case you're curious how we're doing with all of this. This is pretty known information. The next slide, the eviction moratorium and the executive order 12D. So we know that the order as of July 1st has impacted in a good way a drop in new eviction filings for the 6 weeks since, as opposed to the 6 weeks prior. So again, get people to go to Unite CT. That's really the bottom line of that. Anything else to add to that before we go to the presentation? Very excited to have Andrea join us and to talk about 988. So Andrea, take it away.
Thank you so much. I appreciate the invitation to be here today. And so I'm Andrea Duart. I'm from the Connecticut Department of Mental Health and Addiction Services, Prevention and Health Promotion Division at the Commissioner's Office. And I, along with a couple of other co-workers, are at DEMIS and also DCF co-leading the adoption of the 988 for the state of Connecticut. So this presentation will tell you a little bit about what 988 is. Thank you for advancing. and also why we need it essentially, and when you can expect it to be available. So if we can move on, that'd be great. So again, what 988 is, very briefly, I'll give you some overview here, and I'll tell you when you can advance if you don't mind. So back in the past few years, there's been a lot of discussion at the national level about the National Suicide Prevention Lifeline, the 1-800-273-TALK 8255 number, and how challenging, obviously, that long number is to keep in mind, and what it's used for. And so to give you some history, there's been a lot of discussion about, can we come up with a 3-digit number for emotional and mental health crisis? And the grassroots effort starting in Utah really drove this forward. And so there's been a lot of federal initiatives around, working with the agencies, SAMHSA, the Substance Abuse Mental Health Services Administration, the FCC, and et cetera, until the federal act was passed last fall. So I'll give you some more information as we move through this, but essentially the 988 number will coincide with the 800 line. It's the same exact service, but it's going to function a little bit differently. So I can tell you a little bit more about that as we move forward. In advance, thanks. In the interest of time, I won't share this video, but you do have the slide deck. So what you can't see at the bottom is there is a link actually in the deck. So you can take a look at this brief video that kind of talks about the crisis process in terms of the best practice approach through 988. If you can advance to the next one. Thank you. So in Connecticut, if you aren't aware, we have a bifurcated mental health and substance abuse treatment system. So the adults are really supported through Department of Mental Health and Addiction Services, and the children and their families through the Department of Children and Families. So in the crisis service system is also bifurcated, but we're working, especially with 988, closer together to really plan out a more comprehensive approach so that it looks seamless, at least from the outside, to users and also folks that are referring. But I think it's really important that from a baseline understanding that you understand that there are different approaches to obviously when children are in crisis versus when adults are in crisis. Just the first primary information that you should be aware of is when a child's in crisis, typically you have the adult calling, not necessarily a child unless they're teens or a young adult. And even with young adults, once you're 18, you're considered in the adult side of the system. So this particular image was created for through the Crisis Now model and really promoting 988. But one of the strongest advocates for the children's side of services really has been the Connecticut Department of Children and Families. They have a national best practice model for mobile crisis services, and they have had that for 10 years. They do a lot of education and presentations on that. And it was really important. They couldn't be here today, but it was really important from their perspective for me to share that when you're looking at this particular approach, that when it comes to children, if someone is calling about a child, they have the expectation, and it's contractually required, that when someone calls 211 in the state of Connecticut for mobile crisis services for children, that 90% of those calls are going to go to mobile crisis automatically. They never question the caller whether or not mobile is going to go. That's very different on the adult side for the action line through DEMIS. If someone is calling the action line, they have the option to go to mobile crisis as long as they're not necessarily needing an active rescue, like a transfer to 911, if they're an imminent risk based on assessment during the call. And so the majority of adult callers to the crisis line, whether it be 211, the 800 line, or to the action line directly often are resolved at the call center level. It's less common that they would have to go and receive mobile crisis services or necessarily go to a crisis facility. And then certainly there's a small percentage. In fact, it was less than 1% of all calls last year ended up needing an active rescue in collaboration with 911. It's very different on the children's side. So I just wanted to bring that to your attention. If you can advance, please. So I started to get into this just a moment ago, just some of the background drivers for the 988 initiative. And what's most important really is that we now have this, as of last fall, almost a year ago, this National Suicide Hotline Designation Act, which does require all of the states to essentially develop a plan for the implementation of 988. And what a lot of initially we thought this really meant was about just calls, texts, and chat services to enter this door of crisis services, essentially, with all of these different options, predominantly really hoping to get to, to encourage people to reach out early and as often as needed before they get to a crisis. The majority of calls, over 75% of calls to the National Suicide Prevention Hotline, are actually just prevention calls. They're not needing active rescue. It's mental health crisis or emotional health crisis. So they also kind of want to rebrand the line to more of an emotional or mental health crisis line versus just suicide focus. So that's the other purpose around this. If you can advance, please. So why do we need this in Connecticut? It's important to certainly understand the data that's driving a lot of the work, certainly nationally, but I'm going to talk specifically about our state because it does look a little bit different than the rest of the United States. So I'm sharing, the data across the lifespan that we have. So mental health, as you can see, 70%, this is from the Connecticut School Health Survey in 2019, 70% of youth between the 9th and 12th grade are self-reporting that they are stressing out or having experienced depression or emotional issues at least one day in the last 30 days. And then you've got approximately 30% of students that are feeling sad or hopeless. That's like 1 in 4. I mean, it's very concerning that so many kids are feeling this way in high school. Can you advance, please? In terms of suicidal behavior, there 1 in 8 seriously considered suicide during the past 12 months. And in terms of actual attempts, 1 in 15. So you're talking about the average classroom, you've got at least 8 to 15, 8 students that are thinking about it. And it doesn't mean they're necessarily going to act on it. It just means that it's crossing their mind. There are various levels of, thoughts around suicide, what we call a spectrum of thought from, just kind of a fleeting thought to actually having a plan, thinking about means, things like that. And I'm not going to get into a suicide specific presentation today, but if you'd like one in the future, I'd be happy to do that for you. So if you can advance, please. In terms of adults, so this data comes from our Connecticut Behavioral Risk Factor Surveillance System survey of 2018. 1 in 9 individuals over the age of 18 have reported poor mental health. This is a phone survey, by the way, within 30 days. And then depression, 1 in 6. So it's a pretty frequent, the prevalence is high. It's really important that we connect people as quickly as possible when they're starting to feel this way and that they have resources they can connect with 24 hours, 365 days a year. Can you advance, please? Again, depressive episodes, 1 in 12 felt down, depressed, or hopeless more than half the days or nearly half in the past 2 weeks. That's essentially the definition of the clinical definition of depression. And then 1 in 9 felt nervous or anxious. Anxiety, especially among younger populations, is a very high risk determinant for suicide risk, even more so than depression. A lot of that is presented in teens and young adults. So again, this particular survey does cover 18 to 24-year-olds. That's anxiety often is higher in that age group compared to older populations. Can you advance, please? So in 2018, and we do have we have, as of last month, data for suicide, but suicide ideation in terms of the sources, sometimes the data is a little bit dated, in terms of getting it from either the Connecticut Hospital Association or through these surveys. So again, the behavioral risk factor survey is the source of this information. You can see across the age groups, the genders, the ethnicities, excuse me, socioeconomic status, whether they're insured or uninsured, disabled or non-disabled, and then their educational status, what the ideation rates are across, and then percent is 12.4. So it's a pretty concerning picture. Can you please advance? Thank you. So in Connecticut, we have a violent death reporting system, which the Department of Public Health oversees. It's part of a Center for Disease Control grant, and they track all violent deaths, all injuries, opioid overdoses. And so when they look at the causal factors, essentially, and circumstances related to suicide, they could see across these age groups that really the primary concerns are having a perceived depressed mood, and approximately 50% of individuals with depression aren't necessarily, who have died by suicide, aren't necessarily in treatment. The others are. So when we see that there's a history of mental illness or substance use treatment, it's really important. And I'm sorry, that block on the left, for some reason, under 25 also lost its color, but it should be blue as well. You can see they're consistent. The top three factors are similar across all populations. And what we can see by this is it really does help us determine where our interventions need to take place in terms of whether it's prevention or intervention in treatment systems. And so we're working actually in another initiative called the Zero Suicide Learning Community for Health and Behavioral Health Care to activate more suicide prevention and integrate more suicide prevention to reduce risks within populations and treatment. Can you advance, please? Did we skip one? It looked like there may have been a glitch. There we go. And then in 2018 to 2020, let me just say, I'll preface this. We our rate in Connecticut is around 11.9, and the US rate is at 13.9. So we're under the US rate overall. The state of Connecticut is in the top 10 lowest rates of all of the states in DC. With that said, one death is too many. And I should have said at the beginning of this presentation that if any of you have experienced a loss to suicide, whether personally or professionally, I'm very sorry for your loss. I know that the ripple effect is quite extensive and it can really impact us in various ways across time. And we want to be sensitive to people who have had those experiences. So when I'm sharing these numbers, I do want to acknowledge and respect those that have lost their lives to suicide and the survivors. But it's important that we have an understanding of why these resources are needed. So you can see that the rates have pretty much stayed steady, and that is true over time. Even before 2018, we have a relatively low rate compared, but again, one death is too many. You can see how it varies by age at the bottom on the left and also across the graph. And then you can see the big difference because of COVID. There was a huge impact COVID had across the United States. Suicide was reduced by 6%. Connecticut actually experienced a 16% reduction in suicide compared to the US. And you can see where the predominant reductions impacted. It was the 45 to 64-year-olds and the 18 to 24-year-olds. We think a lot of that has to do with the fact that we were all kind of in this together. There's often kind of this this response that people have during times of stress. We're all in this together as a public, health crisis. This, or whether it's a traumatic event, whether it's a school shooting post or 9/11 post. Often you see that the strength of groups supports individuals immediately following these experiences. But what's different with COVID is this is obviously a long-term experience. And so we're not really sure how it's going to impact mental health over time. But preliminarily, because we think people were brought together and there was also more supervision, and people were in closer proximity and things like that, and not wanting to go to the hospital, that it impacted the behaviors related to suicide. We have seen this year, just preliminarily, some increases, kind of back up a little bit, but certainly not exceeding prior years. Can you advance, please? Okay, I think it skipped one. There's a little bit of a glitch. Thank you. So just an overview of the crisis line services at United Way. As I mentioned, we have a DCF and DEMAS partnering together, but our biggest partner in the community, the nonprofit United Way of Connecticut 211, is the call center for a lot of our call services, the mobile crisis services, as well as the 800 line for the National Suicide Prevention Lifeline provider, the mobile crisis provider for youth, and the mobile crisis provider for the adult system. So as I mentioned earlier, the youth side, they're more of like almost like a traffic controller kind of situation. They take the call and then they refer immediately to mobile crisis to perform the assessment on the child. But it's different at the adult mobile crisis side, where they're really doing more at the call center as a service itself. Those call center specialists are helping to diminish the crisis with that adult caller at that moment, versus referring everyone to mobile crisis like on the child side. Excuse me, they've been a National Suicide Prevention Lifeline provider for many, many years. They're accredited by the American Association of Suicidology, as well as the Alliance of Information and Referral Systems. As you know, 211 is the place to go for information and referral. And all of their contact specialists are also crisis trained, and the protocols follow the national guidance around crisis as well. And you can see there, I think I mentioned earlier, that they receive all of these different lines, and depending on how their staff are trained, they will answer certain lines. And in 2020, they had over 122,000 calls. 91% of those were diminished, and 15% needed an active rescue, meaning that those were warm transferred to a 911 for response. Can you advance, please? Okay, hopefully that worked. I don't think did we miss one? No, okay. It seems to glitch sometimes and it skips one. So I mentioned the action line briefly. So this was actually new last fall. I don't know how many of you are familiar with it. We've been working to get it out, but the Department of Mental Health and Addiction Services has contracted with 211, excuse me, to promote the action line. Again, this is the call center that works to diminish the crisis with the caller, as well as, if necessary, will refer to local resources. The idea is that we want people served in the community. They don't need to all go to the hospital, especially if they don't need inpatient services. And we don't want them to necessarily be served by police. Sometimes that can just escalate a situation and can make things worse. So we really want people served at the call center level, and if needed by mobile crisis, to reduce the unnecessary transfer to the hospital and possibly also being arrested. And it also helps to reduce the burden of time spent by the police actually sitting in the emergency room with individuals who may not even need to be there, so that they can respond to other types of emergencies that need and require police attention, as well as reduce the costs related to sending someone to the emergency room, whether it's an ambulance or the cost of an emergency room visit when someone doesn't really need to be there. So there are a lot of reasons to really encourage the upstream approach and encourage folks to reach out early. Was there a question? I'm sorry, I just saw some pop up. I just want to make sure we're answering anything along the way. So under contract, the required on the child side, mobile crisis response is supposed to be within 45 minutes. I don't know the data off the top of my head on the actual, but and then it's an hour and a half for the adult mobile crisis response contractually. And I do believe that the presentation was shared, right? Yes. Okay, great. So here you can see a little bit more about the types of information that or types of resources that are provided when someone does call the action line in Connecticut. And I mentioned some of this before, so I won't get into this, and you have the slides, but essentially the focus is to determine the needs of the caller, really have a person-centered response to whatever their needs may be, and as needed, connect to 911 only under that national protocol guidance if someone is in an imminent risk. Can you advance, please? With the adult mobile crisis services, they are currently really providing services during the day, but as with both actually the child and the adult side, they will be expanded 24 hours in the next 2 years. We don't have the exact timing of that, but part of this is due to the increased resources that the state's receiving through COVID and ARPA. So we're very pleased to be able to do that. And during that time will be when the state is also going to be working on how to sustain those 24-hour services into the future, because this is really what's going to keep people safe in the community, receiving services in the community that they need, and keeping them hopefully there and not in the hospital or in jail, and certainly preventing early and hopefully preventable death. Can you advance, please? So again, the mobile crisis for youth is very different from the adult side. It's very focused on really the access point being that 211 number. You call 211, and I should say, even though there was that 800 line for the action line, you can still call 211 and ask for the action line. If someone does call, what happens is they call 211, press 1 and press 1, and they'll get the child side. And if they press 1 and then 2, they'll get the adult side. So it's the same door, just 2 different options there. Again, the call center is really there to just establish the location and need, and then warm transfer them to the appropriate mobile crisis provider in that child's area. So the emphasis is really on mobile crisis more and responding, and less so on the call center doing to diminish or de-escalate the crisis at the call center level. It really happens more on the mobile crisis level. And they both perform follow-up care as well to anyone that they serve. Can you advance, please? Oh, I think we skipped one. Can you go back one? Okay, there we go. Oh, there it is. So essentially anyone who's 17 and younger is eligible for these services. They also can provide services to anyone who is 18, between like 18 and 19. I think 19 is the limit to the age at which a teen can attend school in Connecticut, I believe. So if that individual is still predominantly in a setting that is youth focused, then they will still serve that child. And certainly we have also engaged youth mobile crisis if there's been a loss or a critical incident with a young adult who's 18 or 19, and where the predominantly impacted group of individuals is youth or our youth. So, and we've also had joint responses with the adult system. So they provide these different kinds of services, predominantly could try to connect them with community-based services. They collaborate with the emergency rooms as needed, and anyone can call on behalf of the child. They serve, parents, doctors' offices, school systems, and again, like I said, the emergency room. Can you advance, please? So I said a little bit of that a moment ago. They also have a variety of different kinds of resources that they have early access to or special access to, and we'll go through that in a minute. And there have been some modifications, obviously, due to COVID. Can you advance, please? So I mentioned earlier that the mobile crisis services on both the child and adult side are going to be advanced to 24/7. 365. When that happens, we will certainly let everybody know as much as we can through various mechanisms. But right now, the services are 6 to 10 during Monday through Friday and 1 to 10 on the weekends. And what happens is these trained clinicians will come to you face-to-face within 45 minutes, as I mentioned earlier as well. Can you advance? So when to call 211 and 988 in the future. So back to 988 a little bit. Just so you know, if you have a cell phone right now and you call 988, you will actually get linked up to the National Suicide Prevention Lifeline. It does currently work, but we have been asked not to promote 988 necessarily until the national kickoff, which is happening in July of 2022. So in the meantime, it's our goal to really put a plan together, make sure that the state is prepared to initiate the calls, text, and chat services for July of 2022, and to make sure that we're connecting with folks like you, as especially people in positions who can refer populations to this service, to just keep, have it on your radar, know that it's coming. Help us, connect to others that can help get the information out to individuals. But essentially, the service will be the same. What's different is that when someone reaches out in the future, and they're still working on this with the FCC and all of the cell phone companies, but they really want to make 988 a geolocated service versus like 911 is now, versus right now what happens is it's triaged based on an area code. So you could be in Florida with your Connecticut cell phone, and because you have an 860 or 203 area code coming in, they're gonna transfer that call to the Connecticut United Way of the United Way of Connecticut to serve you. However, you're in Florida, so if you're needing services in Florida, that's not going to be very helpful. So we've been working to build the capacity of the local provider, United Way, to make sure they have enough staff to staff all of these calls coming in. And right now we're getting, just whatever people, whatever calls with those area codes are coming in. We don't have text and chat services in Connecticut yet, but we will. And with a geolocation, hopefully we'll get more, it'll be more likely that we'll get callers at least in Connecticut, whether, for example, if you're a kid, let's say from Florida attending UConn, and you've got a Florida area code, it won't matter because you're located in Connecticut. So geolocation will ping you to the right provider essentially. And that'll help significantly. One of the challenges we've experienced in responding to having the call center respond to callers who may have a Connecticut phone but are located in another state is we don't know what that state's crisis system's like, right? We've worked really, really hard in Connecticut to do crisis intervention team training so that police and mental health providers are working more collaboratively, that police are more sensitive to mental health and substance issues, are less, are trained to de-escalate, are working with mobile crisis, and so it's challenging and upsetting sometimes when you hear that in other states they don't have those kinds of responses and they come with the lights and sirens to a mental health issue, and it affects people in different ways, usually negatively. And when we hear those kinds of things, there's not much we can do about it right now. If that was something happening in Connecticut, then we could connect with those police and we could connect with the mobile folks and have some continuous quality improvement going on. But we don't really have any control over other states. So I think once the geolocation starts to happen, it'll help improve that response to individuals that might need it that way. The one challenge is that these cell phones, as I'm sure all of you have experienced, sometimes our connections aren't the greatest, and depending on the cell phone towers and the service provider, those towers will sometimes ping you into a location that you're not actually at. So for example, we've heard complaints from the dispatchers in New Haven that sometimes they'll get callers that are actually in Long Island, or you might be close to a border. And so those are things that unfortunately I think we're gonna, have challenges related to moving into the future, but I don't really know what the answer is about that at this point. But anyway, so, when you call 211 for mobile crisis, it's important to have an awareness of what the resources are. So you have that. It's important to understand when to call. You know, when you're going to or sending a person to the emergency room for a mental health evaluation, if they're not an imminent risk, if you really don't think that their life is at risk right now, call mobile crisis. If you can't reach the mental health service provider, call them. If you have called the police but feel this is a mental health issue, call them and they can have a collaborated response. It's also very helpful often to call and request for adults and children if you think that adults and children are both impacted in a situation. Sometimes because the primary focus has been on children, sometimes people haven't requested services for the adults, but really it's both that are needed. So we're encouraging more collaboration across the system between DCF and DMIS to have mobile crisis work together on scene. And also any age person, threatening risk of suicide, is at risk for violence, victimization, or has a trauma experience, in harm's way without immediate assistance, is somehow acting out behaviorally, like I said, is in an emotional or mental health crisis, but may not be communicative about it, is depressed and you're worried, or having some type of other crisis. Again, we're really trying to direct anyone who is not an imminent risk, immediate danger, to 211 and 988 in the future. Anyone else would be through 911. Can you advance, please? So here again, like I said, with 911, it's really imminent risk. So high access to lethal means of some sort, and making sure that, and also if you feel like the situation is maybe needs stabilization or security for some reason, that's a good reason to call the police. Can you advance, please? So one of the things that is part of the 988 planning process is really making sure that the system, that the crisis system overall, from the entry points of the call center, text and chat services, all the way, across that spectrum of services is comprehensive. One thing that we're really fortunate about in Connecticut is that we do have mobile crisis in place already, even though we need to expand it, that we do have a variety of services across from, home-based, community-based, various crisis outpatient services, inpatient services, short-term residential. This gives you a spectrum on the adult side of minimum to kind of more maximum kinds of services that can be received by an individual and not necessarily be in the hospital. Most of the services are really community-based or treatment provider based, not necessarily emergency service based. The reason that someone goes to the emergency room is because they need to be stabilized. And most of the time, those individuals don't actually need to be inpatient. They need one of these other types of services. So that's what we're trying to do with getting them connected to the community versus the hospital emergency room. Can you advance to the child side, please? So here on the child side, you have all of, this is the essentially scope of work that is under the Department of Children and Families. It's providing crisis planning at home, a lot of home-based service, much more honestly, compared to the adult side. We have a lot of home-based services for children. They really don't want children going to the hospital emergency room. We've had a lot of complaints about exposures to, overdoses, other kinds of really traumatic things that happen in the emergency room. We don't want kids witnessing that. If they don't need to absolutely be there. So it's very important to get them connected to the community-based services, which the mobile crisis providers and 211 have information and connections and special access to. Can you advance, please? So, just going back to the 988 planning, again, this is really about the entire crisis system. It's not just about those calls, texts, and chats, but really that is the doorway to the entire system. Excuse me. So it's important that we have adequate coverage. It's important that we have financial stability for these services over time. And we, at this point, have commitment for financial stability through 2025. A lot of states have been introducing legislation to put taxes on cell phone bills. Just like we do for 911, we have our current text for that. We don't know if that's something that will happen in Connecticut in the future, but as of right now, it's not planned to happen. We want to make sure that, that we're covered for a higher capacity. Right now, there's every state received a proposed, capacity, a proposed volume report, essentially from the national folks to say, based on your population, this is what you probably can anticipate. But really, until this starts, we won't have a true measure of what we're really getting ourselves into, other than we know what the calls have been. But with text and chat, it'll be all new. Certainly making sure the performance standards are in place. They are completely up to date for the calls. They're going to have to update everything for text and chat. The multi-stakeholder coalition that's working on developing this plan is in place. We've been meeting since December of last year, and it's very diverse. We have about 37 different individuals representing all kinds of populations and sectors involved in that group. And I'm sure we'll be reaching out to others in the future as we start to roll things out. Making sure that the linkage between 211, quote 988, and 911 are really, really tight. It's been so interesting. I have to just say, I've been in this field for almost 30 years, and I'm learning new things about how that works every single time we talk to the Department of Emergency Services, Public Protection, and their dispatchers. One thing I recently learned, and as also a parent, I was kind of scared about, and I'll share it with you, is that because if we transfer a number or call 911 from our own phone and say, can you, for example, find my child because he took off down the street and I don't know where he is and he's missing, and I know he has his phone, but he's not answering it. They actually can't ask the cell phone provider to ping that person unless the person has called themselves to 911. So for example, with my own 13-year-old, if he had his phone on him, unless he called 911 directly, they couldn't ping him. That's a cell phone privacy law. So we are trying to figure out ways around all of this. And what happens with the cell phone providers right now, we're told by the dispatchers, is that they have to assign a police case number and police officer to it, fill out paperwork, then they can ping the person. Now, obviously, in a time of crisis, that's a process we don't want to have to go through, right? But I understand from a privacy perspective, there are people that may try to ping somebody and get their location who really shouldn't know where that person is, right? There are certain situations like that as well. So this is one of the challenges. I think it'll be one of our biggest challenges for an active rescue situation, especially, if we don't know where that person is, and we have to figure out a way to have the 988 number and a way designated as a mutual aid group. There are many nuances to this. So these are things that we're working out. All that to say, we will work them out. It's just going to take time. It has been 60 years since 911 was adopted through a very similar initiation process. Some, firefighters, grassroots firefighters started, hey, let's have a 3-digit number for emergencies. And that's how that started. We're literally following in the footsteps, but 60 years behind. So it's just going to take time, and people still call 911 for pizza, right? So we're constantly doing education around that. 911 just started their tech services. So we're fortunate to have them partnering with us so that we can learn from them, but it's a constant educational process, especially, with newer folks learning how to use that system. And then we have the follow-up services. So depending on who's providing the service, there will be follow-up to those callers. United Way currently provides follow-up services, so do Mobile Crisis as well. The biggest challenge is certainly what happens if we don't know where that person is or how to get back in touch with that person. So we're working on that. And then the public messaging. So as the national effort starts to roll out, they're going to be giving us more direction as to how they would like us to share about 988, but we're not waiting to start having these conversations. We want to, start getting you all familiar with the fact that it's coming, but we don't yet have, for example, taglines or logos or things like that provided to us. So we will be developing actually a coordinated campaign with a current grant from the CDC at DPH for suicide prevention. We're going to be coordinating the planning process as well as the development and printing and release of all of it. So we're really excited about that coordination. And I think that might be my last slide other than the contact. Can you advance one more? Yeah, so any questions? And I should say, these are the other contacts for you. So Dana is my colleague at Evidence-Based Practices in the Commissioner's Office, and Tim Marshall is at DCF. He oversees children's mental health, community mental health services, and then Wendy Caruso at United Way, who oversees the call center services.
Great. Wow. That's a lot of information. That's really exciting. I'm glad we're doing this. Thank you for your sensitivity to those who have experienced suicide in their families. I guess the one thing I would say to the folks is this isn't just information about our clients. It's also information that we can use personally. So Andrea talked about her 13-year-old child. If you've got folks in your family or even yourself who are having those kind of feelings, these are resources for us that we don't have to sort of keep that arm's length distance from those resources. We should feel free to model good behavior and reach out to services that we need, even as we recommend them to our clients. So Andrea, thanks so much. Are there any questions for Andrea? You have her contact information. We'll go to the next slide in our last minute, which is to remind folks that our steering committee is September 17th. That's when we do the business of the Connecticut Balance of State. And then we'll have COVID office hours again, October 1st. What I would challenge people to do, even though it's at the beginning of the month, is to wear your Halloween, at least your hat. That will prompt me to step up my game and do better than a brown paper bag. And as we close, I would just invite folks to come onto camera and to wave and to say hi to everyone as we attempt to break down some of the isolation that we're experiencing. So good to see you all. Jennifer, thanks for jumping on. Meredith, good to see you. Susie, as always, enjoy your long weekend. As far as anyone knows, this meeting is lasting until 4 o'clock today, wink, wink. So if you're unavailable for the rest of the day, just have your supervisor contact me and I'll swear that you were working to the wee hours of the day. So with that, friends, be well, take care of yourself and those around you.